My section has no math, so we're spared. What's the difference between electrical and mechanical capture? I said electrical is when you can actually see it marching out on the monitor, and mechanical capture is actually when you're feeling the heartbeat matching with the rhythm on the monitor. Again, we've got the difference between absolute and relative refractory period. We can say it all again. Absolute is when the cell cannot respond to any stimulation whatsoever. Relative refractory is when it can get the outside stimulus to get it to fire again, as we just talked about. What are the criteria for determining sinus tachycardia? PR less than 0.20, QRS less than 0.11, or sometimes we're saying like 0.10, I believe, is the other one. And then over 100 beats per minute. So all the criteria for normal sinus, just faster. And the criteria for determining atrial flutter. This is on page 129, table 4.7 out of ECG. Atrial is regular, ventricle is irregular or regular, depending on where the AV conjunction is. Rate is usually from 250 to 350 for typical, and then 350 to 450 for atypical. So there was two sections in there that confused anybody. I apologize, but it's what was in the table. They'll usually hover around 180, no P waves that we can discern in the rhythm, can't really measure the PR interval, and normal QRS. What are the four major electrolytes of the cardiac function? This was in page 31, down in the little table at the bottom: sodium, potassium, calcium, and chloride. Define afterload. The pressure at the left ventricle must push against to get the blood out, page 23. What is the pathophysiology of a junctional escape rhythm, page 154, a rhythm that begins at the AV bundle characterized as a very regular ventricle rate, right around 40 to 60. 142.
Oh, 149, right?
Oh, which one? What's that?
We're at 149 now.
142.
Alright, so 142, what is unstable angina? Unstable angina is considered a precursor to an MI. It is characterized with a lack of response to rest. Treatment and episodes of chest pain usually last longer than 20 minutes. Those are some of the characteristics of it. That's the angina PowerPoint. 143, what is Prinzmetal angina and what are the characteristics of this condition? Prinzmetal angina is a syndrome that results in the abnormal spasm in the coronary artery. This syndrome has a tendency to occur more in younger women at night and may be accompanied with ST elevation. Basically mimics a heart attack, but in a younger population. That too is in the angina PowerPoint. 144, you want to deliver dopamine at 5 mics a kilogram a minute to a patient weighing 250 pounds. You put 800 milligrams of dopamine into a 500 milliliter bag of normal saline. How many drops a minute would this be? Basically just break it down. Dopamine drip of 5 mics per kilogram per minute, 250 pound patient equals roughly 114 kilograms. So you have 5 mics times 114 kilograms times a 60 drip set. Divide that by 1600 equals 21 drips a minute. No page number, that's in our handouts for the algorithms and medications. 145, you want to administer 2 milligrams a minute of lidocaine drip to a patient weighing 100 pounds. You have mixed 1 gram into 250 milliliters of normal saline. How many drops a minute would this be? So in the algorithms that were given to us, we have 30 drips a minute for a lidocaine drip at 2 milligrams a minute. So I went back and broke it all down. So 1 milligram a minute equals 15 drips a minute. 2 was at 30, 3 milligrams a minute is 45, 4 milligrams a minute is 60. Again, that's the drug sheet that Gary handed out to us. 146, you are preparing to administer amiodarone in a patient who is stable ventricular tachycardia. How much will you dispense and how will you administer it to your patient? So this is a live patient. So 150 milligrams, slow push over 10 minutes via IV. Again, reference the drug worksheet. 147, what is the advantage and disadvantage for patients who are taking beta blockers? The advantage of beta blockers is they can keep your blood pressure in check by reducing hypertension. The disadvantage is this can interfere in the body's sympathetic response when it needs to increase the blood pressure for situations such as shock. Don't know what the book page number is, but we talked about it in class several times. 148, what are the three layers of the heart muscle? The three layers of the heart muscle include the epicardium, which is the external layer, the myocardium, which is the middle layer, endocardium, the inner layer. Don't have a page number, but if you want to Google it, you can.
Alright, 149. What are the four phases of the cardiac action potential? The four phases of the cardiac action potential are the rest phase, depolarization phase, the plateau phase, and the repolarization phase. What are the bipolar leads? Bipolar leads are 1, 2, and 3. Name an early sign of hyper K. An early sign of hyper K is a wide, slow bradycardia rhythm with peak T waves, widening QRS, and flattening P waves. Which type of MI would most likely develop a bundle branch block? Had trouble finding this one. I think it's an inferior MI. Is that true?
That's possible. What else could be?
A lateral?
More towards anterior septal.
Anterior.
Okay, so remember it's going to show up in a V1 type thing. So anterior septal is where you bring the legacy in.
Okay, thank you. 153, capnography is dependent on what two functions? That's the patient's exhalation and perfusion. 154, what three rhythms could synchronized cardioversion be used on? SVT, VTAC, rapid AFib or A-flutter. What is the drug dosage and major side effect used in treatment of AFib? I said cardizem, 15 to 20 milligrams. It controls the ventricular rate of the patient with AFib or A-flutter. Major side effects include weakness, nausea, vomiting, and severe hypertension.
Alright, 156, name the characteristics of A-flutter. For rhythm, atrial is regular, ventricular could be regular or irregular depending on AV conduction where the block is. For rate, atrial rate may range from 250 to 450, ventricular rate depends on the AV block, but it normally doesn't exceed 180. There's no identifiable P wave, instead there are sawtooth flutter waves. PRI is not measurable because there's no P wave visible. QRS is usually 0.11 seconds or less, but may be widened if the flutter waves are buried in the QRS. That's out of the EKG book on page 129. 157, what is a drug and its dosage that you would consider administering to a patient in cardiogenic shock? There were two this is Brady volume 4, page 136. One of them is dopamine, 2 to 5 mics per kilogram per minute, or dobutamine at 2.5 to 20 mics per kilogram per minute. And those drug dosages are from the Farm book on page 438 and 439. Name two antiarrhythmic drugs and their dosages used to treat a patient in VTAC with a pulse. Adenosine, 6 milligrams rapid IV push first dose, followed by 12 milligram rapid IV push, and amiodarone, 150 milligrams over 10 minutes. Name at least 5 things that you want to do following a patient in ROSC. This is a long list, but the 5 that were specifically listed were establish ALS care, if it's not established already, keep the patient cool and consider induced therapeutic hypothermia, move patient to the ambulance, being careful not to disrupt established interventions, transport the patient to the nearest appropriate facility, and offer emotional support to the patient throughout care. That's Brady volume 4, page 140. Number 160, name 2 antiarrhythmic drugs and the dosages that may be used for VFib. This is out of the ECG book on page 190. There's amiodarone, 300 milligram dead dose or 150 milligram live dose, and lidocaine, initial bolus of 1 to 1.5 milligrams per kilogram. Question 161, Gary said was deleted. This was from a lecture that we didn't do, and there's nothing that I can find in any of our books about induced hypothermia. 162, what are the components of Beck's triad? Hypotension, JVD, and muffled heart sounds.
I got a quick question for you there. On 1P7, what were the 2 drugs you said?
Dopamine and dobutamine.
Okay, so for us, it would be dopamine. Okay.
Volume 4, page 156.
So, Jerry, let me go back to one that you talked about, and I know that adenosine. If you look at your book, adenosine is described as an antiarrhythmic. Yeah, and I'll buy that. But in terms of VTAC, is it truly what's going to solve this VTAC? No. So what are the 2 antiarrhythmics? You said one, amiodarone.
Right. The other one's a random guess. Is it lidocaine?
Yeah, and so the idea in terms of knowing that dose probably would be a smart move.
Okay, so drop adenosine, add lidocaine.
Yeah, and what we talked about yesterday and what we'll talk about throughout is adenosine is a diagnostic to see whether or not it's going to work.
That was number 1.
Yep.
For cardiogenic shock, Could we administer nitrile? Would that help?
No,
To reduce
because,
it as we
because that would only, remember the way the body will compensate? Nitro will only make that thing worse in terms of the way the body compensates.
Would epi work? Is epi one you
Would
could
epi
give?
work?
Yeah.
Epi would not be your first choice, just because it's gonna cause that pump to work that much harder.
Okay.
163, why is a lidocaine bolus considered prior to intubating a patient with a head injury to prevent any further intracranial pressure? 164, what two things can you do to a patient following apneic oxygenation when their SpO2 isn't above 93%? A big valve mask with peak valve, and an alternative airway like NPA, OPA. 165, an ETCO2 of what indicates inadequate perfusion for patients? 30 to 43, an ETCO2 of 30 to 43 indicates adequate perfusion. A PaCO2 of 35 to 45 indicates adequate perfusion. Name 3 indications for the use of calcium chloride and what is its dosage? Acute hyperkalemia, acute hypocalcemia, calcium channel blocker overdose. Dose is 2 to 4 milligrams per kilogram of a 10% solution that may be repeated at 10-minute intervals. 167, name 3 indications for the use of sodium bicarbonate dosage. Tricyclic antidepressant overdose, severe acidosis refractory to hyperventilation. There were only 2 in the pharmacology book, so I added in press injury. Dose is 1 milliequivalent per kilogram initially, followed by 0.5 milliequivalent per kilogram every 10 minutes as indicated by Fluid gas studies. 168, what is the indication of vasopressin and what is its dosage? The indication is for cardiac arrest. The dose is 40 units IV, single dose only. What is an indication of ondansetron and what is its dosage? Nausea, vomiting, dose of 48 milligrams.
170 in the lecture on hypertension. Gary spoke about different classes of drugs used to treat hypertension. LOLs, pines, mides, and prils. So LOLs are beta blockers, adrenergic receptor antagonists. Pines are calcium channel blockers. Mides are diuretics. Prils are ACE inhibitors. What is the difference between hypertensive urgency and hypertensive crisis or emergency? That was in the hypertension lecture. Hypertensive urgency is hypertension causing end-organ damage that isn't acute and may have some symptoms of elevated hypertension. Hypertensive emergency is hypertension associated with end-organ damage in which blood pressure needs to be lowered emergently. 172, name the beta-1 drug and dosage used for treatment in cardiac arrest. 1 milligram epi every 3 to 5 minutes. What are contiguous leads? 2 leads are contiguous if they look at the same or adjacent area of the heart, or they are numerically consecutive chest leads. 174. Oh, that was in on page 76 of the 12-lead book. 174. Name 4 complications of a person with an MI. Hypotension, cardiogenic shock, arrhythmias, and flash pulmonary edema. Page 132 of the 12-lead book. Well, 175, what is pulmonary hypertension? It's increased pressure in the pulmonary arteries. 176, when would calcium chloride be used and what's the correct dosage from the drug profiles? Acute hyperkalemia, acute hypocalcemia, calcium channel blocker overdose, and antidote for magnesium sulfate. Dose is 2 to 4 milligrams per kilogram at 10% solution and may be repeated at 10-minute intervals.
Okay, and I'm going to take it back for 177. What should you consider using sodium bicarbonate? What is the correct dosage? But suspect patient may be acidic from press injury, long downtime, or tricyclic overdose. The dose is 1 millikilo per kilogram. Redose half millikilo per kilogram every 5 to 10. The 178 was the treatment algorithm for a patient with rapid AFib. We have that in our algorithm packet. And that concludes the outside.
So let me just add one other thing. For today, it's not important. In a couple weeks, it will be. So Jessica talked about bicarb, uses of bicarb. What's one other thing outside Dr. Edminster kind of got there last week after your 12 week? Hyper K definitely, what else? Crush injury, right? Metabolic acidosis severe, what else? What was that? Tricyclic overdose, okay? And again, you're not, and I know you're not knee deep into this quite yet, but it's coming. TCA overdose will be the other reason for giving bicarb, and we'll talk some more about those times ago.
What about syphilis? Will it work for that? Syphilis?
Not that I'm aware of, but I just, you can try it.
I'm asking for a friend.
Just for the possibility.